Just a couple of housekeeping items. We're trying to get Dr. Grichnik hooked up to us on Zoom, so we'll wait for her for a minute or two. And what I'll do, because she and I have already had the opportunity to speak for a few minutes beforehand, is I'll prognosticate a little bit for you what we're going to talk about this morning. She leads a significant anesthesia service in the Tampa, Greater Florida, and at a national level. And so we're going to talk about the changes that have occurred in the care of the surgical patient, the perioperative environment of the care of patients, and some of the implications that has a much broader view and perspective than we're used to. We're going to share with you a little bit what she and I feel are the impacts of that. We're going to talk a little bit about opportunities for assistance with implementation. And then at the end, I'm going to try and give you a few minutes for questions and answers. From a housekeeping standpoint, she's here in front of me. So rather than having me do this or walk around with my back to you, I'll sit here and we'll talk. This is going to be a very casual fireside chat environment. And I would like you to take a moment as we go along to consider questions that you might have. And Dr. Grichnik has joined us.
Good morning, everybody.
So there is a backstory here. I also should be in Tampa because that's where I came from. I was smart enough to take a job with Novant 3 months ago, so I get to sit here. But I've been watching it very carefully. Fortunately or unfortunately for Fort Myers, the storm has turned a little bit more towards them, and Tampa, which would have not been a good recipient of this storm, has gotten a little bit out of the way, but it's still pretty exciting down there. Hope all is well with you, Dr. Grichnik.
Yeah, and my regrets for not being with you there in person. It was the right decision to stay home and make sure we were battened down. The storm is not quite into Tampa yet. We're a little bit south, but a great deal of rain. And the thing I'm mostly grateful for is that I have power and internet. So I'm able to join you and have this great conversation.
And we're grateful for that as well. So let's go ahead and get on into it. What I wanted to start out with, and you've been very kind to go ahead and cue up the first slide that speaks to it. When I started in training, the continuum of care or the perioperative continuum started somewhere around either the patient arriving to the holding area or when the incision was made or antibiotics were given, and it ended when the patient left the PACU. Why don't you take a little bit of time and tell us how that's expanded and what a modern and contemporary view of the continuum of care for the perioperative surgical patient is in your mind?
What a fabulous question, because I think Dr. Butler is exactly spot on that the continuum of care has expanded from multiple points of view, especially from the patient, from the caregivers, from our facilities, and from our health plans, if you will. We all work together, even at the point of the decision to have a patient come, in my case, to an ambulatory surgery center, or in Dr. Butler's case, maybe to the hospital or a hospital outpatient department. But there's an operative decision that is primarily driven by the surgeon, but your anesthesia provider and your administrators can have some be of assistance. And what I mean by that is who's appropriate. Who's appropriate for what care setting? What are the right kinds of decisions that we should make about where a patient would be cared for? With the patient, of course, because it's always a mutual decision. And then with that, how do we get people optimized to have a surgical procedure in the appropriate care setting? So way back at the time for the operative decision is actually where we all should be involved. Then you move on through to this preoperative optimization time period. And that would be, do we need somebody to maybe get their diabetes under control a little bit better? Or should that patient have more blood pressure medication adjustment? Again, all those things matter on the post-op side. So most of the time, Dr. Butler and I and our colleagues, our administrative, nursing, care team colleagues can manage through a surgery, but what we really care about is how people do afterwards. And of course, that's what people care about, patients. And then you come into the time admission. So there's a lot of preoperative things that go on as soon as a patient enters into an OR care suite. And again, it could be a hospital, it could be a hospital outpatient department or an ambulatory setting. We all work precisely together during the intraoperative part. And then in the post-op part, we also have a range of things that we work on together. So our Dr. Butler should be absolutely worried or be on top of any incisional problems, any potential problems with bleeding. I, on the other hand, should be absolutely on top of any pain or nausea, or if our patient's a little bit sedated. All of those things we divide and conquer. And then our nursing colleagues, our care team colleagues also work with us to make sure that all of our therapies are effective, if you will. But discharges is really an important question. So that goes back to the operative decision. Should our patients stay in-house one day? Should they be going home that day? Should we be extending care for 23 hours? You can see that the continuum of care is huge. And it's not just walking in the OR and walking out of the OR, because now we work together.
Thank you. And you've all been exposed as a result of this. This is a great slide, and you can see what a pleasure it is to work with Dr. Grichnik. This is a really good demonstration of what a new look at the care of the surgical patient is in both the ambulatory and the inpatient environment. She'll be familiar with it. You may or may not have had exposure, but ASA published papers going back to as far back as 2013, the Society of Anesthesia, starting to talk about something called perioperative surgical home. And that was this concept, essentially. But this is a morphing of that over time, and this is our current 2022 iteration. So I guess the question I have for you, Dr. Grichnik, is, are we now well past proof of concept, and this is something that we need to do?
Dr. Butler, you're challenging me here. No, that's a great question. So Dr. Butler is absolutely correct that this we're well past proof of concept. So we know that this is a construct that works, that when we all work together, that we actually can both achieve better outcomes, but also measure better outcomes. Because at the end of the day, a perioperative surgical home says, I'm going to measure the differences that we achieve by working together at the very beginning, be that fewer complications, be that a shorter length of stay, be that reduced infections. I think that the barriers have been around implementation. And the implementation involves multiple care teams. And it is not just our surgeons, our anesthesiologists, our nurses, our care team members, but now it involves supply chain. It could involve sterile processing. It could involve pharmacy. How do we get our drugs in? So when you set up a perioperative surgical home, you have to set it up with the notion that you've got a lot of people involved to help you on that decision making. And it is easier to do for some types of surgery and maybe less easy to do for others. And then you have to consider the care setting: hospital, outpatients, hospital, ambulatory care. And I think it has had various degrees of adoption in each of those care settings.
I'd like to touch on a couple of the concepts that you mentioned. Our hospital operators, the people that write the checks for all this, their question always is, what's the bang for the buck? So and you touched on outcomes, wound infections, readmissions. Is there a real opportunity here to positively affect care? Does perioperative surgical home, does this continuum have the ability to deliver on that request?
So I believe it does. And there's lots. So Dr. Butler is correct that there's a financial, there's a patient, there is how do we all work together, and even from staffing satisfaction, but also our labor costs. But when I think about a perioperative surgical home, I can measure it in multiple different ways. First is simply patient satisfaction. We can measure that through HCAHPS. We can measure that through CCAHPS, CHCAHPS, which is in and outpatient settings. We could measure it on simple use of things. If it's complicated surgery, did I have fewer blood transfusions? Did I have fewer extended cares? I could measure it on same-day cancellations. So did my patient come in and get canceled because they were lacking a test or weren't quite ready? But there's some real things that the hospitals care about, and there's penalties and benefits at the hospital level with things like hospital-acquired infections, conditions, HTACs, hospital-acquired infections. We have Medicare readmission penalties. You've got Medicare spend per beneficiary things that hospitals pay attention to. So there's value-based purchasing elements that hit the hospital side, including those things that I mentioned. And there's our patient satisfaction. And there's how do we work together from a care team delivery such that we are able to be efficient and effective.
And the second thing I wanted to touch on, and you've led me very nicely, is we've kind of heard an undercurrent in your discussion of fragmentation. CMS has given us a mixed message over the years, our insurance carriers. A couple of questions or your responses. Do you feel like we're now seeing a unification of a move towards continuous care to our patients? And are we leaving fragmentation behind, or is it still a significant obstacle to us?
I think in some care settings, fragmentation's better. I think it's still an obstacle. So I'm going to bring it back to a different way to look at it. So when Dr. Butler delivers care, he's thinking about it from the point of view is I've got my primary care provider who's referring me a patient for surgery. I need to make sure that I take care of my patient, that I deliver the care, that I'm able to do my clinic at the same time I'm going to the OR, at the same time I'm trying to decide, am I working in the hospital in the morning or the ambulatory setting in the afternoon? The anesthesiologist might be looking at it from, I've got to make sure that this patient is optimized for surgery, that there's a set of comorbidities associated with my patient, but also with the surgery itself, and then what's the right care setting. Our facilities may be looking at it from the point of view is, how do I even make this work from a scheduling point of view? Who's where, what, when? And at the end of the day, our patients need to know what to do in order to take care of themselves, but also have efficient and effective care delivery. So I think the fragmentation is really still there. And it's not because of anybody being, it's not because we don't want to work together, it's just harder to work together. And I would say there's a technology piece that could help us out if we could all see the same scheduling. If we all understood what our hospitals are doing versus our ambulatory centers versus our outpatient departments. But right now, we have different systems, and I would say surgeons probably work across systems more than any other, and anesthesiologists more than any other type of care provider.
So that leads me to the next question. A few years ago, we had a president that gave us the great gift of an electronic medical record mandate, and that's going to solve everything. At least it was supposed to. And they were going to talk to each other, they were going to intercommunicate, and all that fragmentation was going to end. So how have we done? Has the EMR delivered on the promise? Has it gotten in our way? What has the electronic medical record done for us?
Okay, so I think that somewhat depends on who you're talking to. And I think it also depends on whether we're talking about acute care delivery or outpatient care delivery. So I'm gonna keep it to the acute care because that's what I'm most familiar with. I think my outpatient colleagues would have maybe a different perception. I believe that the electronic medical record was absolutely the right thing to do, to think about. I mean, I should be able to get on the night before surgery, see my patient, their entire history, if you will, whether they are at a hospital. I used to work in North Carolina, whether they're a hospital in Charlotte or a hospital in Durham, right? I should be able to get on and look at their history. That is not possible the way that the electronic medical records are set up today. One, because we have different EMR systems between Epic and Cerner and others. And then within each instance, a hospital may have one instance of an electronic medical record that is not able to be seen by another hospital. So that's just on the hospital side. Now translated into the outpatient side, where it was not a mandate to implement an electronic medical record on the outpatient surgical side. So we have a difference between, most hospitals have some form of an electronic medical record, not translatable between hospitals, but that doesn't necessarily go to the ambulatory setting or vice versa. So we have a mismatch, if you will, of information being exchanged between an acute care and an ambulatory setting. So I think that the promise of delivery of information was profound and great, and we should be doing it. The way it was implemented hasn't worked very well. And I would actually challenge Dr. Butler to tell me what it's like to be a person who works in multiple different care settings and perhaps across multiple different EMRs.
Oh, it's a thrill a minute. That's the bottom line. It's remembering all the different passwords. It's remembering the different order sets. It's remembering what this program will do and that program won't. It's remembering the nuances against what one's performance is measured and wanting to meet those performance expectations, but realize that one or two clicks that you forgot because you forgot what system you were working on made the difference between success and failure. And it very much makes us much more directed at caring for the computer and the program than the patient sometimes. And that's exactly what we did not want this to achieve. But I do agree with you philosophically, absolutely positively the right decision. Absolutely positively there's many, many things we take for granted today that we have immediate access to. I remember going to the x-ray room, pulling the films out of the jackets and throwing them on a view box. The ability to bring an image up instantaneously now, to see lab instantaneously now, has brought us a long way, but it has also made us drunk on the unrealized potential that electronic medical record offers us. So I guess—
And unfortunately, our patients think that there is a unified record.
Yes, they do.
And there isn't. And I think that's a little bit of the knowledge gap, that, you know, there's a big record out there on every person. Well, there's not. And so we still are hunting and gathering.
Yes, I would extend that. There's not a provider that you can speak to, whether it's a nurse practitioner or a nurse or a physician, an anesthesiologist, a surgeon in any office, that you can't ask that very question. That, have you had a patient come and say, well, I'm from XYZ out of state? You have my record, don't you? No. and they're devastated. They cannot begin to understand how that's not the case, because they too bought into the mandate. So the next question out of that then is, with this continuum of care that we're talking about, with the tools that we have, with where we've gotten on the path, and within the context of the health economics that we're living in, inflation, labor challenges, supply chain, is it a realistic vision to unify all of this and come up with a system that we can actually sustain, and that we can actually afford, that provides this excellence of care?
Well, I'm going to go back a little bit to what you first said about the perioperative surgical home, because I do think it's possible. And I think it gives us a construct, if you will, for value-based care. And I think that's where you're going. Is it achievable for us to have the benefits of value-based care, which is basically the outcomes, best outcomes for patients, in a way that we deliver care efficiently, effectively for everybody involved? And so that would be the cost of care, that would be patient satisfaction, that would be provider satisfaction. So there's a lot of, and then of course, best outcomes. So there's a lot of pieces to the puzzle, and I think it is possible. I don't think it can be a big bang theory. I think it has to be implemented over time with the appropriate either surgical procedures or patient conditions, right? Because again, you and I are in the acute care setting, but there's a whole world of outpatient chronic disease that also would benefit from value-based care. And I think philosophically, it is always the right thing to pay for health, to pay for prevention, to pay for best outcomes. How we get there is spelled out actually through a construct called the perioperative surgical home, which has elements that I've listed here. The enhanced recovery after surgery really is giving you the protocols and processes that will allow you to achieve best outcomes. And multimodal analgesia says we're going to tackle things like the opioid crisis by reducing some of the drugs that we're using, or using them in small quantities together, so that we can get to the right protocol, so that we can get to the right outcomes. So I think I'm not quite answering your question directly. I think it's possible. I think you have to measure the right things. And I think you have to start at the beginning and start slowly, and then move it across the appropriate surgical procedures.
So we've done a little bit of past situation. We've talked a little bit about present. So let's get out the crystal ball. You're the
Okay.
feature speaker, so we'll ask you to get out the crystal ball and tell us, with this potential that we have, with this opportunity to get out of the fee-for-service canoe and get into the value-based canoe, and with the consensus that this is the right canoe to be in, who's going to steward us through that? What are the solutions going to be? Is it a digital solution like the EMR supposedly was a few years ago and maybe we just missed on it? Are there analog solutions? Are there workflow solutions? Is this industrial engineering solutions? What in your vision gets us to future state?
Well, you probably named all the things that I would have said. So let's start with that. So first of all, from a digital point of view, I don't see a lot of this working very well unless we can connect the dots between the point of decision to have a surgical procedure in your office to the point of discharge and even follow up 30 to 60 to 90 days later. So how do we connect those dots between what you see, what I see, what our facilities see, what our other care team members see? And so we have a disparate set of IT systems right now that bring those things together. And if we don't do that, then we actually risk patient safety. So if I don't necessarily know, for instance, what implant you want or what lens you might want because it's in your notes that are handwritten in your office and it doesn't make its way to the facility, then we have a gap, a safety gap. So there has to be some sort of a digital methodology to get there. I think our patients are a big piece of this. I think actually our patients are driving a lot of this. So patients are driving it from the point of view that they are using a lot of electronic means now to find out a lot about us. They want to know whether we're the right care providers. They want to know whether the facility itself has good safety outcomes. They want to know whether the patient experience of seeing you, seeing me, or being at our facilities is a good experience. And so not only are they using some electronic tools to make decisions, but now we are also asking patients on the back end to tell us about their own outcomes. It's called patient-reported outcome measures, PROMs. So now we can incorporate our patients' information and feedback into some of the tweaks, you might say, that we can make to our processes. So getting to your engineering. So there is a labor and a workforce flow that has to happen in order to achieve the kinds of outcomes that you expect, that I expect, that our patients expect. So again, digitally, if I know all the information and I've got my patient who's optimized, who is coming in for a pre-op, we're not late, we're not canceling cases, everything flows through the day, then you end up with people working together in a better way than potentially waiting, having somebody have downtime who's inactive, that's just a labor cost, or somebody who's upset because this case is late and I know that I have a patient waiting in my clinic. Or I have people who are asked to stay late because we started late and now we're paying overtime. So there is a workforce efficiency and labor that also comes from this. And at the end of the day, if we're going to talk about dollars and cents, it is how do you manage the dollars and cents of your medical costs, from supplies to meds to labor to overtime, which is labor. And then how do you manage the complications, right? Because now we're also being held accountable for a readmission, for an infection, for a post-op complication. So there's at least 4 or 5 different pieces to the puzzle that I do think start at the very beginning with how do we pull all the right information together in the right place so that we can all see it and then work on these things together. I think the real key to the puzzle is how do we hold people accountable to that? And in some ways, our health systems are right in there, trying talking a lot about value-based care and what are the accountable metrics that prove value-based care at the end of the day.
So
Food for thought.
Indeed, and that's kind of where I'm at right now. We're sitting here at an innovation seminar. It would seem to me, and I'd like you to correct me if I'm wrong or amplify if I'm right, that the last 15 minutes or so that we've spent together identifies tremendous opportunities within this space for innovation and solutions and disruptive answers.
I would absolutely agree with you, but one of the things I think we need to be aware of is that any hospital might have, I'm going to say, 200 different IT solutions. And the challenge for this technology conference is going to be knitting those things together. So knitting together, how does pharmacy order their medications with a surgical scheduling process, with an optimization process, with how do I even know that my patient was readmitted after a procedure to a different hospital from the one that they had the procedure in. So there's in some ways, I view a technology solution as being a cloud-based that would pull together a bunch of IT solutions that are so disparate right now. I don't think, again, we can do any kind of a big bang where we're just going to swipe it away and put in one IT system. That doesn't work, right? But we have to be able to pull the different pieces together and then make them available for people to use to create those efficiencies, to create those outcomes, to create those best practices. I don't think I have the answer to that, but I think that is exactly where we need to be going. And again, I would parse it out. I would chunk it out. Let's talk about a IT solution for the pre-op, or let's say from the point of decision to operate through pre-op. How do I pull just those pieces of the puzzle together? Link it up to the intra-op, link it up to post-op. But we have to start somewhere. And so starting and chunking it out, as well as choosing which procedures we would do this with, seems logical to me.
So it sounds to me like what we're talking about, and I very much agree with you, is that we're also going to need to ask our vendors, our solution providers, to cast off their traditional models of proprietary ownership. There may need to be a common cloud-based sharing and transparency of data upon which then they put their unique product or twist that allows us to most optimally do it. And I think that's going to be a big challenge for them. Your thoughts on that?
Well, it's not a challenge for them, but it's also a challenge for privacy, right? Which is a big concern of patients, of hospitals. And we know, especially with the number of hacks, if you will, to our data that occur daily in any hospital system, that the security is going to be very important. So the challenge there is the right thing to do. I think the challenge, again, would be how do we take a proof of concept, say I can do it here, what's called the pre-op, I can do it for this procedure, it's secure, I'm not violating patient rights, you're able to see it, everybody's able to see what we need to see so we can work together and we get something at the end of the day. But there's a lot of considerations there. I mean, irrespective of the actual IT work, the technology work that goes into doing that.
So if I was a really difficult moderator, I'd ask you whether or not privacy even really exists anymore, but we know that it does, and it's governed in healthcare. But
I actually think it's whether or not it does exist anymore, it matters to people.
It does.
So I think that we always have to take that into consideration, what our patients' wishes and expectations are.
Well, the good news is you've answered in 10 seconds what I thought might take us another hour. And that's a good thing because we've only got a couple of minutes left. So does anyone have any questions for Dr. Grichnik or myself or anything they'd like to hear discussed in any more detail? Yes, sir.
I'm with Kepler, and I love that you are talking about technology because I come from that world. And there are innovations available in the open market. Like one company I can think of is Particle Health that provides that interoperability of data. So from your perspective, what are the barriers to actual implementations outside of technology? Like, is there a lack of pain on the hospital side or on the payer side because the patient feels the pain and no one in the system really feels the pain? Or are there other reasons for those innovations that are available in the market are not being fully implemented into like all EMRs? Thank you.
Dr. Grichnik, were you able to hear the question okay?
I was, and I'm trying to think about how to thoughtfully answer that. So there's a lot of worry about proprietary information. I think that the hospitals worry about having proprietary information can be shared in a way with a competitor or with people who might be inappropriate to get that information. Similarly, I think a lot of the not the IT systems, but the EMR systems have the same concern. So getting a big system, and I'll just choose Epic or Cerner or one of the others to say, I'm going to share my information with this cloud-based solution is a significant conversation in and of itself. So you have both the hospital, you've got the actual EMR system itself, and then as I alluded to before, we have a fragmentation across. I've got a tiny EMR system, let's say in an office-based setting, that needs to link up to the hospital-based setting. So both of those need to talk, and then both of those need to talk to the cloud-based. You are absolutely correct. Patients, I expect, right, that this should be absolutely possible, but the barriers you run into almost right away are around what data is appropriate to share. How can I make my systems talk to each other? How can I give you information without betraying something that would either betray a confidentiality issue or lead somebody to be more successful than me?
Sitting in my chair as a system physician executive for Novant, I could not agree more with what Dr. Grichnik has said. You know, the barriers are confidentiality of the data, proper marshaling of it. Overlying that is we have regulatory responsibilities, so we always have to take that into account. And then the other thing is many of these products now come from startups or relatively new companies, and when you're talking about large health systems, there's a desire to make sure that there's stability and longevity present. No matter how good the solution is, there needs to be street credibility that they'll be here tomorrow and next year when issues may come up. And then, and then the big bad word in the room, there are no new dollars flowing into healthcare. So money doesn't talk, it screams. It always comes down to the cost and the business case. And the business case is demonstrating an outcome that justifies the cost, and that is getting harder and harder. Dr. Grichnik did a nice job a few minutes ago talking about some of the measurable outcomes, but the better we get at this game, and everybody asks us to get better and better, those measurable outcomes and having significant impact on them gets harder and harder, and it becomes more and more challenging for the business case. And unfortunately, all the things around us and all the things that were around us last evening at the demonstration, they're not getting less expensive, they're getting more expensive. So it's a challenge. I'm
going to echo that challenge. The financial challenge is profound. Yeah. And there's a pie of money now. It's not getting bigger. It's how do you slice it up in order to achieve the goals. I'm not saying it's not doable. And I'm not saying we shouldn't do it. We just have to figure out how.
So this concludes our time. It's been a real pleasure to moderate this session. Dr. Grichnik, we wish you the best with Ian.
Thank you very much.
Try and get him to behave. I hope you all enjoyed the session. Wish you the best in the balance of your day.
All right. Take care, everybody.